Prasad, did he come?
Yes, ma'am. Came, ma'am. 1 minute, madam.
నేను co-host చేయాలా?
అయిపోయింది మేడం. మీరు జాయిన్ అవుతున్నారు. జస్ట్ అది స్క్రీన్ షేర్ చేస్తున్నాము. మీరు ఇంకా స్టార్ట్ చేస్తారు మేడం.
ఎవరు co-host ఇప్పుడు? No, co-host ఎవరు?
Yes, good afternoon to everybody, and good afternoon to respected madams and my dear colleagues who are participating in this live topic with me. So, first of all, my wishes and congratulations for all medical laboratory colleagues. So we are celebrating Medical Laboratory Professionals Week. So on this occasion, they have given me an opportunity to participate in live session with one topic. So today I am going to take the topic is slide. Madam, I'm not able to see.
మేడం స్లైడ్ షేర్ చేయడానికి ఇవ్వండి మేడం.
అదే ఒక్క నిమిషం. You can start, ma'am.
మేడం హోస్ట్ డిజేబుల్ పార్టిసిపెంట్ స్క్రీన్ షేరింగ్ అని వస్తుంది మేడం.
నువ్వు దేంట్లోంచి షేర్ చేస్తున్నావు ప్రసాద్?
ఇది సిస్టమ్ మేడం.
హోస్ట్ చేసా నేను. ఉన్నట్టునే ఒక్క నిమిషం. ఇప్పుడు చూడు.
ఒక్క నిమిషం మేడం.
Yes. Okay. Yes, Jalandhar, you can start, ma'am. You are muted.
Today our topic is serology of autoimmune hemolytic anemia.
Yes, you're audible now.
The contents are autoimmune hemolytic anemia and causes for autoimmune hemolytic anemia and the classification of hemolytic anemia, serological tests in autoimmune hemolytic anemia, types of auto antibodies, lab tests detected by cold autoantibodies, warm autoantibodies in autoimmune hemolytic anemia, and serology, drug-induced hemolytic anemia. So now we'll go one by one. So what is autoimmune hemolytic anemia? Autoimmune hemolytic anemia is known to occur when patient produces antibodies that are directed to his or her own red cell antigen. Also, drug-induced hemolytic anemia is due to the development of an autoantibody causing damage to the patient RBCs due to a particular drug or drug complex. Now, we'll go for causes. So, what are the causes for autoimmune hemolytic anemia? There are many causes for the development of autoantibodies to self-antigens. One of the important causes is the failure of the self-immune mechanisms, which are known to regulate the production of antibodies by B lymphocytes, the antibody-producing cells, that is, the helper T cells assist B cells in producing antibody, while suppressor T cells control the excessive production of antibodies. Next, loss or suppressor T cell function due to the microbial agents or drugs may result in antibody development. Next, findings. So, what findings we can see in autoimmune hemolytic anemia? In a typical case, autoimmune hemolytic anemia, the presence of autoantibodies react with patient's own cells, along with a positive DAT is observed. Some cases may not show anemia due to accelerated production of RBCs, but most cases usually show decreased hemoglobin and hematocrit levels. Next, the reticulocyte count and unconjugated bilirubin will be increased, by hepatoglobin levels may decrease. Next, hemoglobinemia or hemoglobinuria may occur. These are the findings we can see in autoimmune hemolytic anemia. And next, what are the findings we can see in autoimmune hemolytic anemia? Serological tests in autoimmune hemolytic anemia. So, what test we can do in autoimmune hemolytic anemia? The DAT using polyspecific and or monospecific reagents, test for autoantibody presence. Next, the characterization of autoantibody serum and elute by testing with panel of test cells and thermal amplitude of antibody reactivity. Types of autoantibodies. Autoantibodies are divided into two main groups depending on the optimal temperature of reactivity: cold autoantibodies and warm autoantibodies. We can see the percentage of autoantibodies in autoimmune hemolytic anemia. About 70% of the reported autoimmune hemolytic anemia cases reacted at 37 degrees Celsius, and about 18% of the reported autoimmune hemolytic anemia cases reacted at 4 to 30 degrees Celsius. About 12% of the reported autoimmune hemolytic anemia cases are drug-induced. Therefore, characterization of autoantibodies is important, as treatment and problem solving differ according to optimum temperature of reactivity. Next, cold agglutinin. Cold agglutinin are basically of two types: benign, pathologic, and cold agglutinin, as shown in this table. We can see the characters, and benign we can classify as benign cold and pathologic cold. So, what are the characters of benign cold antibodies and pathologic cold antibodies? The thermal amplitude. Benign cold antibodies we can find at less than 20 degrees Celsius, and pathologic cold antibodies we can find up to 32 degrees Celsius. And titers, we can find benign cold autoantibodies less than 64, and pathologic cold antibodies we can find more than 1000 dilution at 4 degrees Celsius. Next, we can use the techniques, testing techniques. We can use albumin, enzyme technique. So, in this benign cold antibodies, we cannot find anything, but in pathologic cold antibodies, increased reactivity we can find. and a clinical signs. Benign cold antibodies, nothing will be there. But in pathology cold antibodies we can find in autoimmune hemolytic anemia. So next, if we go for direct antiglobulin test, so we can find it is negative or weak positive with polyspecific antiglobulin reagent, and we can find strong positive with polyspecific antiglobulin reagent in pathology cold antibodies. Next. So what are the lab tests? Lab tests affected by cold autoantibodies. Cold autoantibodies sometimes interfere with routine serum and cell grouping. So we can see in ABO grouping, false positive reactions are seen with routine ABO reagents as cells are coated with auto cold antibodies. So valid results can be obtained after washing cells with warm saline at 37 degrees Celsius. If more stained agglutinins are present, after collecting the specimen can be kept at 37 degrees Celsius. Next, we can use a thiol or dithiothiotol can be used to disperse the auto agglutinations. If we go for RH grouping, false positive reactions are often seen when RBC coated with cold autoantibodies are tested. Washing cells with warm saline will usually give good results, as cold autoagglutination can activate the complement cascade in vitro, means test tube. These binds to RBCs, leading to false positive results in weak B or due results in the indirect antiglobulin test. And this problem may be solved by EDTA test tube. EAT, direct antiglobulin test. If patient blood collected in EDTA, corrected results are obtained, but in a clotted specimen, complement activation takes place, leading to false positive results. Antibody detection and identification. Cold autoagglutinins reacts best at 4 degrees Celsius, but are not detected in routine testing. Is not done at this temperature. Cold antibodies bind to cells at lower temperature when cells are in contact with serum, but may cause problem as complement is activated and C3 remains attached to red cells and gets agglutinated with polyspecific antiglobulin reagents. Reactions are stronger when enzyme treated cells are used, as most hemolytic antibodies are detected by indirect antiglobulin test. These non-specific reactions of C3 in this phase must be investigated, as the non-specific reactors may mask the specific reactions. Also use the IgG immunoglobulins. IgG antiglobulin serum may eliminate most problems. Next, compatibility test. See, if you go for cross-matching in autoimmune hemolytic anemia cases, the most common antibody encountered is anti-I, as I antigen is a ubiquitous antigen present in all RBCs. There are problems, however, indication of the antibody, use of pre-warmed or auto-absorbed serum or with IgG also helps acquiring incompatible blood. Next, specificity. See, specifically, anti-I is the most commonly encountered antibody. While anti is relatively uncommon, anti-H is also found in A1 and A1B persons. Also, anti-H is commonly found in A1 and AB persons. It is fairly easy to identify the antibodies using combination of antigens in panel of cells. Next, if we go for yes. Slide is not there actually. It's a different kind of not look at this slide. Okay, so I can explain over and yeah, continue cycle. So if you go for pathology cold agglutinates, mild to sometimes severe life-threatening lysis may be caused by some pathologic agglutinates. Example, cold reactive hemolytic anemia, usually associated with mycoplasma, pneumonia infection or infection mononucleases. Okay, cold hemoglobin disease or idiopathic cold autoimmune hemolytic anemia. 16% of cases are usually seen in older patients. Next. During winter, intravascular lysis due to complement results in hemoglobinuria. Significant findings are DAT positive by polyspecific antisera, also with monospecific anti-C3 antisera. Cold autoantibody titers of 1000 or greater by saline at 4 degrees Celsius with visible agglutination at room temperature. Warm autoantibodies in autoimmune hemolytic anemia. About 70% of autoimmune hemolytic anemia cases are of the warm type. However, there are also harmless warm autoantibody, and it is not easy to differentiate between the two. Warm autoimmune hemolytic anemia may be idiopathic or secondary to a pathologic disorder, but anemia is present requires hemolysis is caused by IgG antibody. Indirect urobilinogen or increases.
Concentration doubt was.
In severe cases, depleted serum haptoglobin or hemoglobinuria and increasing LDH, lactic dehydrogenase or seen. Serology. Autoantibodies in warm autoimmune hemolytic anemia react best by enzymes, albumin or indirect antiglobulin test technique. They are known to activate complement, usually a high incidence antigen, often within the RH system may be involved, but others, blood group system antigens are also known to react. Problems caused by warm autoimmune hemolytic antibodies. As both alloantibodies and autoantibodies are warm reacting problems may be encountered. APO grouping may not be affected and warm autoantibodies may not agglutinate auto A1 and B cells. If you go for direct antiglobulin test, positive DAT result is expected. The patient may contain a mixture of auto plus allo antibodies or only auto antibodies. Specifically, testing with a panel of cells by saline, bovine albumin, and indirect antiglobulin test should give correct picture. An elute prepared from the patient's RBCs when tested with a panel of cells may show specificity. Identifying the specificity may also help in selecting blood for transfusion. Compatible units for patients with warm autoimmune hemolytic anemia are very difficult to obtain. Therefore, least incompatible RBCs may be selected for transfusion. If we go for another type of anemia, drug-induced immune hemolytic anemia, this is quite rare. However, it is to be suspected if patient is taking drugs. The DAT is usually positive. Once the drug is withdrawn, the patient recovers rapidly. If we go for drug-induced anemia, so we can identify some of the mechanisms related to drugs. So in all the cases, we can find direct antiglobulin test is positive, and the interfering antibodies, there is a probability of IgM or IgG. If we go for quinine, phenazepam drug, so the mechanism is immune complex formation. In this case, we can find direct antiglobulin test is positive. The antibodies involved are IgM or IgG. And if you go for elute testing, we can identify it may be negative. And hemolysis, yes, hemolysis is present with renal failure. If we go for another drug, penicillin or cephalosporins or streptomycin, in this case also, we can find direct antiglobulin test is positive and the involved antibodies are IgG antibodies. In this case also, we can identify elute may come as negative. So in this case, 3 to 4% with large doses of extravascular hemolysis will be present. And if you go for another drug, cephalosporins, in this, so what is the mechanism? So membrane modification will be occurred, and in this case also we can find direct antiglobulin test is positive and elute may be negative. So hemolysis, there may be may or may not be present hemolysis. And the fourth drug is methyl dopa. So aldomate. So in this case also we can find direct antiglobulin test is positive and the antibodies involved are IgG. So we can find elute come positive and hemolysis chances are 0.8%. So these are the possibilities of autoimmune hemolytic anemia by using drugs. So in these cases, if we find any positive, then we can advise to stop the drug. Then patient may get recovered. And see, this is the conclusion to my topic. And if any doubts, please ask me and I will clarify, dear colleagues. And I am requesting madams also, if any means hello. Hello.
Yes,
Hello.
Jalandhar.
Okay. Should I go for transport or?
You're finished, huh? Jalandhar?
Yes, ma'am. Ma'am. Hello.
Yes. Any questions?
Hearing, ma'am. Hello.
Hello?
Hello.
Am I audible here?
Hello. Very low voice, ma'am. I'm unable to hear properly. Hello. Hello. Hello.
Ma'am, control it, ma'am.
Yeah. Hello? Are you able to hear me, Jalandhar?
Yeah, yes, ma'am.
Okay.
Hello.
Some network issue, I think, but anyhow. Yeah, thank you for your extensive talk.
Yes, ma'am. Hello. Thank you, ma'am.
Any questions?
Yes, ma'am. Hello.
Any questions? Any questions? Yeah, thank you, Jalandhar, for your extensive talk.
Thank you very much, ma'am. Thank you very much.
Yeah. So we'll resume with another talk tomorrow. Yeah, thank you one and all for joining.
Thank you, ma'am.
Yes, thank you one and all for joining.